Of course, there are three types of anticoagulants, oral anticoagulants, and each one will have their own distinct recommendations. For vitamin K antagonism or warfarin related ICHs, the Canadian guidelines that we published in 2021 recommend that PCC be used, or prothrombin complex concentrate, at a dose of 30 units per kilogram to a maximum of 3,000 units, and that patients should also get IV vitamin K 10 milligrams to avoid rebound increase in their INR. In the European Stroke Organization recommendation is very similar, except they provide a different dosing strategy according to INR at presentation. And there is various dosing algorithms out there based on the institution regarding dosing of PCC in people who have vitamin K related ICHs according to either body weight, INR, or a combination of both. Now, when it comes to direct thrombin inhibitors or Dabigatran, we had the direct reversal agent that's available is Idarucizumab. That's also an intravenous medication where you give a total of 5 milligram dose in two separate 2.5 milligram injections. Those injections should be given as soon as possible, one after the other, and no more than 15 minutes apart. If Idarucizumab is not available for whatever the reason in a particular hospital, then factor VIII bypassing activity would be the next kind of preferred agent, or FIBA. And if that's not available, then PCC. When it comes to factor Xa inhibitor associated ICH, so that's either hemorrhages that occur on not on asundexian, that's actually a factor 11 inhibitor that we're going to be speaking about in a second. But hemorrhages that occur on Apixaban, Rivaroxaban, or Edoxaban, then we do have a direct reversal agent that's been approved in Europe and the United States, and that's Andexanet alfa. And if that is not available, so just currently in Canada where I practice, the recommendation is, again, prothrombin complex concentrate at a dose of 50 units per kilogram here, higher than that we recommend for VKA-related hemorrhages, but again, to a maximum of 3,000 units. However, I would say based on the totality of evidence at present, and I'll also just mention that since ESOC, we've just announced that the Andexanet study, which is testing Andexanet alfa versus usual care, has been stopped at predetermined interim analysis for overwhelming efficacy of Andexanet alfa over usual care for the primary outcome of the trial, which was obtaining hemostatic efficacy. So I would say if the drug is available to you at present, based on the totality of evidence we already had published, and particularly now this added information that you're getting much more robust hemostatic efficacy with Andexanet alfa versus PCC in this randomized study, the details of which have yet to be kind of published or presented publicly, that Andexanet alfa should be your number one choice.